Good morning, friends. I hope everyone had a restful holiday season, but it's 2026 now, so we need to buckle in because we're already riding this ride. I'm going to go straight into it. We're going to start with state stuff and move to federal. Um, the state legislature is back, and generally in the second year of the two-year legislative cycle, this is a pretty frantic time. Insiders call it the silly season because you often see many, many bills that legislators may have been working on over the whole 2 years that are suddenly introduced because if they're not introduced soon, they won't be. And for generally between January and maybe the end of February is a pretty frantic time. The legislature often wants to be done as early as possible in the spring because that extends the amount of time they have to campaign and run for a re-election. So we're really looking at, again, much like Congress, a very narrow amount of time to get a lot of things done or not. So what are we watching for at the end of the legislative session? Some of the issues on the screen will be familiar to you because we've talked about them before, in some cases for many months. For example, the additional money that the Department of Health Services needs to implement the new federal requirements for SNAP that were part of HR 1. That is still not passed and not moving. There are some other bills that have been either introduced or are about to be introduced that can impact people with disabilities. And in the last couple of months, we have learned of a few programs where the amount of money that the state legislature budgeted in the budget that they passed in July has turned out to not be enough to cover the actual cost of the program. Special education is one of those items, and funding for the Division of Vocational Rehab Habilitation is another item. So we should be prepared to be very watchful and may be prepared to respond very quickly. We're now in the place where the legislature is trying to do as many things as they can, and that often means that they are giving 24 hours notice before, say, a public hearing, and there's a lot of not a lot of clarity sometimes when you're trying to move fast and not a lot of time to get information out and have people engage with the process. Also in December, Wisconsin I, which many disability advocates had really taken advantage of to kind of watch what committee hearings and what legislators were saying, that has not had enough funding to continue, and so remains disabled at this point, which means that you will still be able to watch the floor sessions. A floor session is when like the entire assembly gets together to vote on the bills that it has decided it wants to vote on. But you aren't able to watch the individual committee hearings anymore, and that is that is a big loss for the disability community. The other things to watch, and I will kind of be previewing in a little longer term strategy in a moment. There are a number of things that are indications that if they are not resolved now before the legislature ends its session, will mean that we are starting with quite a bit less money than we need to meet the obligations that were promised in this two-year budget. Remember, Wisconsin has a two-year budget cycle. So the current budget that we passed in July of 2025 actually is supposed to cover all of the costs of Wisconsin's programs through June 30th of 2027. Okay, so we're kind of it's kind of an odd cycle. And then when the new legislature comes back in next January, they will be talking about a budget for 2027, 2029. So if we are unable to, kind of make sure that everything we promised would be funded is funded to the level it needs to be to meet the obligations for this budget cycle, that means when a new legislature comes back, all of those programs that were kind of in the red now are going to not be in the red and probably deeper in the red because costs always continue to rise at a moment where we expect that the next budget cycle is really where we're going to start feeling the impacts as a state of the Medicaid cuts and SNAP changes that occurred as part of HR 1, as well as some other federal changes. So where are we in terms of gaps in our current state budget? Well, in November, we talked about a $140 million less than what is needed to cover special education. Essentially, the legislature promised a certain reimbursement rate, but they set a fixed amount of money aside to cover it, and that amount of money wasn't enough to meet that reimbursement rate. So we're $140 million short there. The Department of Health Services has said we need $70 million more dollars in order to be able to comply with all of the new requirements for SNAP that are required for HR 1. And those requirements have already started to go into effect. So essentially, by not having had that money approved in August, as the department asked, we are now at the point where some of the implementation dates have passed, and they do not have the staffing or the system changes needed to fully be able to do good, to keep doing a high level and a good job, and make sure that the error rate is low. And it's important for the state to have a low error rate because one of the provisions of HR 1 is that if your error rate is too high as a state, you have to pay a lot, a good part of the cost of SNAP, whereas states now don't have to pay, pay any match in order to get federal money for food assistance. So we are at the point where we are already starting to see consequences of failing to act there because, as you know, it takes time to get staff hired and trained, and we really rely on the expertise of good people to help, make sure that our systems are running without mistakes and without any fraud. So that's an upper that has not been dealt with. In, I think, November, the Department of Vocational Rehabilitation said that they did not have enough money to meet the need that they are seeing go through the door, that the amount of money budgeted was not enough, and they have already implemented a wait list for people who are seeking help with employment services. And then just this week, the Wisconsin Medicaid program ran its numbers and projected that they would have a $213 million deficit by the end of this budget year, June 30th, 2027. If you're keeping track at home, that's almost $500 million that we would be short going into the next budget cycle if the legislature does not act. Now, is there some wiggle room in these numbers? Yes. Actually, the Medicaid projection has changed, and they run this, several times because, you don't know how many people are going to be in Medicaid or what they need. So some of this projected, shortfall is because drug prices have increased. Specifically, however, they also named long-term care, both facility-based care and the children's long-term care program and family care as having higher than expected usage and costs. So, there is room for, these numbers to change. It should be noted, though, that the Medicaid Medicaid was estimating a $140 million shortfall a few months ago, and the shortfall is continuing to increase. So this is what we know of right now. Um, there are also some ongoing changes that may impact, whether or not the amount that the state budget has right now is enough, or if we're creating more gaps. And we'll talk a little bit about the Affordable Care Act in a moment, but there um, can definitely be some unexpected gaps in budgets that are due to outside influences. For example, Wisconsin has a reinsurance fund that is intended to help insurers cover the costs if they have more high cost people in the insurance pool who are needing more health care, and the amount that the entire insurance pool is putting in is not sufficient to kind of cover the higher usage folks. It is unknown at this point what the federal changes and also the expired ACA subsidies will mean for how many people are in the Affordable Care Act market and what kind of coverage they have. And this is anticipated to be an evolving story, but it could actually have a state budget impact that is unknown at this point. There have also been, in the last year, if you've been following with us, many cuts at the federal level. Some of those cuts were to grants or awards that people had expected they would get, and they won't. Maybe they have enough money where they can run for another year or two before they run out of money. But a year or two is exactly when the next state budget cycle is. There are also some federal funding that has just been eliminated. And so there are gaps that exist now that were not expected when this budget passed in July. A good example of that, a relatively small but important example that's disability related, is the Wisconsin Deaf-Blind Technical Assistance Program. That was a $500,000 grant that was supposed to be a 5-year grant. And in August, the U.S. Department of Education said, we're going to cancel that grant in the middle of the grant award period. In other words, they had 3 years left on that grant where they were expecting that money to keep coming into the state, and all of a sudden it was gone. 170 deaf-blind students were left without the program that supported them. We scrambled, we meaning the Department of Public Instruction as a state, and there was a nonprofit that provided funding for this school year, because this grant got canceled in August, which obviously the school year starts in September. But that money is running out in September of 2026, and there isn't a replacement for it. So that's an example of the federal government made a promise and then changed that promise, and now there is a shortfall there that after September 2026, there isn't another source of money to fund that program. That program will be in trouble before the next budget cycle, but it's a good example of there have been many changes like that that could end up impacting the state budget and or what local nonprofits or local governments are able to fund and do. A little bit on the Affordable Care Act. You're going to find that I'm going to give you lots of reading homework and links. We're not necessarily going to go through every article that has been out, because there has been a lot of coverage. The Affordable Care Act subsidies have expired as of January 1st. So all of that discussion that we had from November to now about will they, won't they extend the Affordable Care Act subsidies, the answer so far is no. And most of the coverage of the subsidy expirations has been about what will this mean for people who are currently in the marketplace or are looking to get into the marketplace? In other words, we have about 22 million people who are insured through the marketplace. Their premiums are going to go up, in some cases very, very high, depending on your age and your healthcare needs and where you live. There are people who will have to change plans because the insurance plan they have now is deciding to not offer a plan this year. Lots and lots of coverage of what are the decisions that people are going to make, and will they choose to pay more to have the same plan? Will they have to move down to a plan that is lower cost but also lower coverage, or a different kind of plan that maybe doesn't have to provide the same coverage as the Affordable Care Act? Or will they leave the market altogether and either become uninsured or lower their income and end up in Medicaid? We still don't have the answers to what have people who are already in the marketplace done. The open enrollment period goes through next week, January 15th. There's been a lot of attention on what were people going to do by December 15th, because if you wanted coverage starting January 1st this year, that was when you had to act. But the actual enrollment period closes next week. And there's also been some coverage of, well, even if people signed up for certain plans to meet the deadline that they had to get coverage January 1st, the first billing cycle will also be telling, because sometimes what happens is people will, make a decision on the plan, and perhaps they were hoping that Congress might act or hoping their finances would be different. And sometimes what happens is they don't pay that first premium bill, which means that they essentially cancel their coverage, right? So there's a lot of focus on what are the people who are in the marketplace now going to do. But the reality is these changes that are happening, and they're not only the expiration of the subsidies, there's also been, some administrative changes in the federal agencies to really encourage people to enroll in lower cost and lower coverage plans. These changes will keep rolling as we go forward. So there are people who would be coming into the market for a variety of reasons outside of open enrollment. Perhaps they are changing jobs and moving from a job that had employer health insurance to another job that doesn't, or they're adding a family member, or either through birth or getting married, or they're moving, across the country and you have to change insurance plans. So, the reality of the costs are higher now, and there isn't the subsidies are not there, will continue to influence everyone who is going to be now considering what their plan options are, going forward. And states are in a position where they really don't know what the decisions are that all the people who are already in the marketplace have made, and what impact that may have on, the insurance pool and the market in itself, and what it might mean for people who are looking for insurance going forward. So, there may be, we will learn more in the coming months about what the expiration of the subsidies has resulted in. The other reality is we will also be learning more about what does it mean to the healthcare system when you have a much larger group of people who perhaps has insurance, but it's insurance that covers a lot less or requires the individual to pay a lot more. There hasn't been as much coverage at this point about what do these changes and the decisions that people have made and are making now going to mean for the amount of uncompensated care and the amount of individual medical debt and bankruptcies that might result if people who have lower cost plans that have higher deductibles or coinsurance or copay requirements end up having to have expensive health care that they can't cover. So there's a number of articles out there, and the basic bottom line is stay tuned. This is a developing story that is going to continue to have a ripple effect for state budgets and for the healthcare system. And no, there really isn't a way for states to make up for the expired credits that Congress has not renewed. There have been a lot of the coverage, often using individuals, people, and their stories to try and illustrate what is the immediate impact of, premiums going up and these plans becoming harder for people to afford. And there's a whole slew of stories on this page. You can read them at your leverage or your leisure. One story I'll feature is from one of our former board members, a young man with a disability who is talking about, what do the changes mean for him as a person who has ongoing healthcare needs and lives independently, and is working. What do these premium changes actually mean for his personal insurance program premiums? We've talked a little bit about how there are some kind of larger assumptions about people with disabilities. It is important that people understand people with disabilities are not only in Medicaid. People with disabilities are working. They are participating in the workforce. Some of them have employer-sponsored insurance. Some of them are insured through the Affordable Care Act marketplace. Some of them are on Medicare. Some of them are on Medicaid. Some of them are on Medicaid and Medicare. And some of them are working in the medical assistance purchase plan and maybe have some part of their coverage covered by an employer and Medicaid and Medicare. There's this assumption that, well, if you're with a person with a disability, then you're in Medicaid, out of sight, out of mind, and you're taken care of. And I think it is important for us to kind of remind people that that's not where all people with disabilities are. And also, Medicaid is a poverty-based program, which means if you decide that there's a group of people that it's okay for them that's Medicaid is where they have to go because they can't get the care they need anywhere else, which is truly the situation. You are committing those people to having to stay poor in order to qualify for the care that they need. And I think through the past year, many of you have engaged with neighbors and other people who just have no idea what your real experience is. I know it's really hard to say the same hard things over and over and over again and to open up each time to a reporter who maybe doesn't know all these things, or a legislator, or do these things in public. I mean, it is difficult to have to share the most intimate and personal parts of our lives, but it's also really important because we're in a moment where it is very important to clearly say what is true and what your reality and your experience is. And if other people start to question that, it is not your responsibility to educate or argue or try and convince. It is important for you to say what is true, because chances are there are other people who have the same reality and the same experience who are going to say, yes, me too. And it might encourage them to also say what is happening to them and enable them to take further action. So there are lots of folks, and I think this will be true in the next year, who will kind of want to shout down or say things that say your reality isn't true or challenge you on it, you can turn off the comments on your social media. You can delete comments. You can block people. You can simply say, that is not my experience, or that is not true, and leave it at that. It is not your job to educate every random person online, but it is really important that we keep saying things because reporters are relying on these stories to help them understand. And if you are running into a reporter who really needs more background on, how the systems work for people with disabilities, you can always refer them to us. We are happy to talk with reporters and spend some time saying, hey, here's the pieces of the system and here's how folks we hear from people all over the state and how they're experiencing the system. You can always do that, but they do want to always connect with real individuals. It's a very time-honored strategy to telling these stories. So I know it's very hard, and I know many of you have done a lot in the past year to kind of elevate and talk about very personal things. And I think it is going to be as important this next year and beyond to keep doing that. For some of you who attended our last webinar, this will be a little bit repetitive, but I want to give folks kind of a long-term picture of where we are in terms of disability issues and advocacy for the next 2 years, really. Right now, we are in a position where the state legislature is either going to make decisions or not. They are going to do and pass legislation and pass additional funding or not. And they're going to do it probably between January and March. Much like Congress, the Assembly has, in the last several sessions, said that they want to be done first, and often they have a strategy of passing all of what they're going to do and then adjourning the session and leaving town and kind of saying, well, we did what we could do and now it's up to the Senate, right? So I expect that we could see that again. And the idea in the Senate will then have a defined list of things that they can either approve or not approve. And that will be what happens. There's one committee that can come in even when regular session is out. That is the Budget Writing Joint Finance Committee. However, we are in an election year, so it is to the advantage of all currently elected members who are running for re-election that once they adjourn the session, they really turn their focus to campaigning. And you're starting to see that already. There are lots of bills being introduced that maybe don't really have a chance, a realistic shot at becoming law, but they're being introduced to kind of show potential voters, hey, here's something that we think you'll like. Regardless of whether it becomes law, it's a signal to potential voters or something that they can point to and say they've done, even if it hasn't really moved into a position of being reality. So it's unlikely that once the regular session is done, that even the Joint Finance Committee that can come in and say, approve, budget items, that they will do that. So this next 7 weeks is kind of, in my view, really the opportunity for us to shore up those holes that we know exist in the current state budget now. And if it doesn't happen by the end of regular session, yes, joint finance could come in again, but they have to decide to do that, and they get to decide what's on the agenda. And it becomes very hard for advocates to push for that outside of a regular session in an election year. March 19th is Disability Advocacy Day, so put that on your calendar. We are going to talk about the federal 2026 budget, which is not finalized yet. But unbelievably, in May, we start the federal appropriations process for 2027. So we're barely getting the 2026 budget process resolved before in a few months, we're going to be back where we were last May, where we have the president introducing his ideas of what to fund, and there might be cuts or other things in that. And then Congress has to start this 12 bill appropriation process over again. We are also going to start to see in the next year implementation of some of the requirements for HR 1. In June, CMS is required to provide states with some amount of guidance on how states can or should implement the Medicaid Prove You're Working or Prove You're Exempt requirements. CMS issued some sort of guidance document in December that was essentially repeating what was in the statute. So most states said, well, that isn't helpful because it's not any more information than we have, and it's not telling us what we need to do in terms of how do we change our systems to comply with the law. In August, we have an election. We have a lot of elections this year. Every state assembly representative runs every 2 years. We have half of the state senate that has to run, and we have a governor's election this year. And in some places, there are multiple candidates from the same party who are running. And so in August, the voters decide which of the Democratic candidates and which of the Republican candidates, you have to kind of vote in one primary or the other, will end up being on the November ballot. I'm actually skipping an election. There's a Supreme Court election in April as well. So we have some significant elections that are happening in the state this year, and all of our congressional representatives are also up for re-election. By September, states are when it comes to the Prove You're Working and Prove You're Exempt requirements, they have to be in place by this time next year. So there really isn't a lot of time for states to figure out how to make this work, and then how to inform all of the people that it applies to what they have to do. They have to start communicating about those changes in September, which also happens to be the end of the federal fiscal year. So if the federal 2027 budget isn't in place by the end of the fiscal year, we're in the same situation that we were in this fall, where either Congress has to act and do a continuing resolution, or we're shutting down various agencies as part of a governor shutdown. November is elections. So we will have a new governor. We will likely have new legislators. That governor position is important because between November and really February, a tremendous amount of change happens at the state agencies. The governor has to hire staff. They have to make agency appointments. A lot of the leadership at all of our state agencies are appointments. And they have to do the really important work of doing the first draft of the 2027-2029 budget. And remember, what our state legislature does now will determine how much of a gap there is between what the actual cost of doing business is and where we're starting the next budget cycle. So whomever's elected governor is going to have several big jobs right away. And one of those jobs is going to be to figure out, what do you propose for a new state budget? And it is highly likely that budget will have some very deep cuts to it, especially if you are entering the new budget cycle with lots of needs that were unaddressed from this cycle. By December, the new legislature starts picking its leaders, like who's the majority and the minority leader, and who are the chairs of the committees and who's on what committees. They decide what rules they want for themselves. And then, January, our new legislature is seated, and those prove your working requirements start. So by next year, a whole bunch of policy stuff has happened. And usually in January, you will see the same kind of cycle in the legislature where lots of bills are introduced. Some returning members of the legislature are introducing bills that they drafted before. A new Congress will be seated. And by February of next year, we are going to be starting our state budget process. The governor usually introduces their budget first. There's actually a date specified in the statute by which they have to give that budget to the legislature. And then those important joint finance committee members have some important decisions. They have to decide whether they're starting with the governor's budget or not. And in the past several cycles, they have chosen to not start with the governor's proposal. They've kind of gone with the base budget and made adjustments from there. So between March and really June, there becomes that will be the window where a lot of the cuts or a lot of the funding that may be necessary for lots of disability programs will be decided. And it will either be the same or probably reduced. This is a hard cycle to get increases. And that's challenging because a lot of the programs people with disabilities rely on are public programs, and some of them are high cost. Think of home and community-based long-term care like Family Care and Iris and Children's Long-Term Care Support Program. And even small changes can make a big difference in individual people's lives. So we really are in a place where the advocacy on the next state budget is going to be pretty intense. And we will start to see, the major impacts of HR 1 hitting states in that cycle. And we went through the rest of the year, but you can kind of see that it feels like there should be a break after 2025. And really, we are in a position where we're setting up for a pretty important conversation about what is it that the state pays for and what doesn't it pay for a little over a year from now. Survival is doing some kind of intensive grassroots trainings. I want to just note, if you haven't already registered, that we did have a change in one of the dates. So it will now be a late January and 2 February dates. Unfortunately, the presenter had a family emergency come up. So originally we were registered for next week. So if you have already registered, you should have gotten a note about the date changes. But if you haven't registered already, you have a little more time to commit to those trainings. Congress. The ACA subsidies have expired, and Congress has 15 working days to pass legislation. They have 9 budget appropriation bills that need to be passed. They have to decide if they are going to retroactively do something about the Affordable Care Act subsidies, or if they're going to move any sort of healthcare package. This week, the House passed 3 appropriation bills, and they are some of the less controversial of the 9 that are left. The House also passed a discharge petition that had some bipartisan support, and that petition enabled the proposal to simply extend the former ACA subsidies for another 3 years. A lot of people are making a big deal out of this. This is a strategy. There are many moderate Republican members who understand that the much higher costs for healthcare for their constituents might mean that those constituents will be angry and might not want to vote for them. So there's a group of Republicans that is very nervous that the failure to extend subsidies is going to translate into voters not voting for them. And they have their colleagues, many of them do not feel like the subsidies should be extended at all. So they joined essentially with the Democrats and said, here's our proposal. Do the same thing we've been doing for 3 more years. And if that sounds familiar, it's because what it is. That is the proposal that the Democrats in the US Senate have brought up and had voted down 16 times, maybe more, last year. And it is the easiest thing to do. And it probably is now, especially now that the subsidies have expired, it is the thing that Congress could do that would cause the least amount of confusion for consumers and the least amount of work for states. So I'm not begrudging the policy approach here, especially in this moment of time, but folks should see it for what it is. This is a way that House Republican members can raise their hand and say, I voted to extend the subsidies. But they also know that the US Senate is highly unlikely to pass the same thing that they just voted for. So it's a way to signal, I've heard you and I support extending the subsidies while knowing that that vote likely won't turn into anything real for your consumers. Next week, the Senate is expected to pass the 3 budget bills the House passed this week. So that takes us down to 6 appropriation bills remaining. And there's some debate about what bills the Senate might be prepared to move forward next week. But it looks like up to 3 more appropriation bills might be part of what the Senate does next week. And of course, the House has to approve those bills. Importantly, the bills that have the most impact to people with disabilities and the bills that are the highest cost are not going forward next week. And I have a little bit of insight from our national policy people that I'll pass on to you in the next slide. Next week, January 15th, is the end of the ACA open enrollment. That's an important date. It's next Thursday. The US Senate, at this point, the only thing that has passed is the House resolution to extend the subsidies for 3 years, which the Senate is not planning to take up. There is a small group of senators who says they want to do something. They may have legislative text revealed for the first time on Tuesday. Remember that the open enrollment date is next Thursday. So I'm just setting that up for you so that when we talk about next week, what is their proposal, know that that proposal is unlikely to pass before the open enrollment period has ended. And even if whatever they propose does eventually pass, now it will be done after people had to make a decision about whether or not they were in the market, and that leads to a whole bunch of other considerations. So the last week that the Senate is in session, remember Congress has 15 session days to pass legislation. We've used 5 of them this week, so we have 10 left. And the last week they have any time to do any business is January 26th to the 30th. And the 30th is important because that is the deadline when the current continuing resolution expires. So whatever budget appropriation bills have not passed both houses and been signed into law by the president, that will mean that Congress will have to pass another continuing resolution if they want to keep those agencies that are covered by the budgets they haven't dealt with open and functioning. So much like our state legislature, you start to see some parallels between the state houses and Congress. This is again the second year of a 2-year term in Congress, and that will mean that federal lawmakers will also want to spend less time in Washington, D.C., and more time back home talking to potential voters. And so that means there's a real incentive to finish business early in the year so they have more time to campaign. It also means that whatever doesn't pass very soon might not pass at all, and that Congress will not necessarily be present or come back into session if there are actions the executive branch takes that might need congressional oversight. So once Congress leaves town, they aren't there to kind of mind the store and provide, do that oversight function as much as they were perhaps last year. We'll start with the federal 2026 budget. My national public policy person yesterday, and things change every 5 minutes, so who knows? This may or may not be accurate by next week. But she has said that Congress is not going to have the defense or the labor HHS education bill, negotiated where both sides agree before the January 30th when, they either have to pass a continuing resolution or the government shuts down. Part of what is happening is that the recent foreign intervention into Venezuela and also the actions of federal ICE law enforcement in the past week have really derailed the appropriations process that Congress thought it would be doing this month. They were anticipating to be able to focus the entire month of January on appropriations. And now that kind of these other outside events have happened, there is a lot more interest by congressional members to kind of look at changing those budget bills more to either add language or take away funding, and they're looking at these budget bills as being leverage and also maybe the only vehicle to move some of their policy priorities forward. And so there's a lot more kind of jostling around, and things that were maybe thought were settled appear to be more up in the air now. Why are we focused on the labor, HHS, and education bill? It's the bill where a lot of the stuff that impacts people with disabilities the most is. It's also one of the two most expensive budget appropriation bills out of the 12. Defense and the labor HHS education bill make up 70% of the discretional spending the federal government does. They are the most costly and often the most controversial of all 12 of the bills. So the good news is that Congress has been very clear they want to pass a permanent budget using the regular appropriations process. And part of that is because they saw through the last year, as we all did, what the administration did when, on its own, when there was a continuing resolution in place that was perhaps less firm about, the discretion that the Office of Management of a Budget used to decide what programs to fund or impound funds or other things. So Congress seems to be very deliberate this time in trying to pass a budget that is statute that perhaps provides more structure about the intent of Congress and more enforceability about making sure that what is in the statute is actually how those funds get spent. Congress is not interested in another shutdown, which means that by January 30th, if the defense and labor HHS education budgets aren't passed, they will pass a continuing resolution to continue to work on those bills. When I asked the question, what would the new date for a continuing resolution be? There was a speculative guess that the new deadline wouldn't be later than March, which makes sense because in May we start the 2027 budget process. But it does mean that knowing that there isn't a willingness to shut the government down also means that members who want to add language and know that whatever's in that bill is going to pass versus be objected to, and a government shutdown is the biggest leverage the minority has to stop legislation. It may give members more leverage to demand more things be either added or taken out of those two bills. So what's in the labor HHS education bill? Medicaid, all of the disability Act programs, Older Americans Act programs, other aging and disability programs, special education, vocational rehab, some pretty big pieces of things that impact people with disabilities' lives. And at this point, many of the committees that had discussed these bills had kept most things level funded and not made many changes. So we don't know now that these are going to be the last two bills to go, and now that there is a bigger desire to make changes and less of a desire to oppose changes and stop a bill from moving forward, what that will mean for funding for lots of different programs. Same questions. I mean, I think all of us have seen what our state legislators and what our federal lawmakers have either done or not done. And we have a whole year of 2025 where lots of things that had never happened before happened, and without a lot of consequence or objection. So again, the same questions we've been saying are important are still important because we don't have anything finalized for major sections of the budget that impact people with disabilities. And it's important to have some sort of guarantee and something on the record that commits funding to the programs that are important to us. Talked a little bit about this. The Senate, there are some senators who are working on some version of an Affordable Care Act extension. Importantly, that version has a lot of different changes included in it. Some of these changes are going to be familiar to you because they've been discussed really since November. And we've had a lot of discussion about, well, if you make changes from what states know what to do if the subsidies expire or if the current subsidies are renewed and put in place. What they don't know what to do is how to incorporate changes to the current subsidies that will really impact how they calculate premiums, etc. So the proposal the Senate is working on is very different from the old subsidies. It's a 2-year extension, first of all, and it changes who could get the subsidies. It makes every plan have premiums and gives people the choice to put subsidies either towards reduced premiums or into HSAs, and it has a number of other changes that might happen in the second year of the program. The major thing that was discussed this week is some agreement that this unknown piece of legislation to which no one has text, this is all rumors about what is in it, but it's similar to the ideas that have been discussed before. The major discussion this week was, when do we extend the open enrollment period? And apparently a date of March was floated out there. Most members are saying we're either going to do something in the near future or we're not going to do anything at all. And most watchers, including our national policy folks, do not expect that Congress will actually extend subsidies in any form. But this is now the last pathway. There are some people who were hoping that if the House passed, which they did, passed the bill to extend the expired ACA subsidies for 3 more years, that would really encourage this other alternative to have some legs and move forward. It remains to be seen if that will be the case. Regardless, whatever the Senate passes has to be able to pass the House. So, and there's, again, 10 session days left in Congress to get this worked out and get it through not only the U.S. Senate, but the U.S. House. So it is important for members to understand how people are experiencing healthcare. And our national person is a big fan of constituents, calling members and asking them to open up a constituent case. I think that's a great idea. And, it at least elevates constituents are calling with these concerns, and is there any way that you can resolve them? Many of the questions that you see on here are going to be things that are occurring because of actions Congress has taken. But sometimes members of Congress can help individual constituents resolve an issue. So there's always that chance. And if nothing else, when people start calling in and asking for actual service from their congressional members, because things are happening to them because of policy changes that Congress has made, it does elevate the issue. Congress also has to figure out if they're going to do anything more on healthcare, especially if they're not going to deal with the expired ACA subsidies. However, it remains unclear what that might be. There's another factor. We have had one member of Congress resign from the Republican side, and unfortunately, another member died this week. So the number of the majority has narrowed. And remember, the majority, if you all vote together as one, you can pass bills without having, any member from the other party agreeing to them. So that is how HR 1 passed, where, all of the Republicans, voted together as a bloc to say yes to the bill. And the Democrats did not have enough people voting no to cause that bill to fail. But now the number of people and Republicans is smaller, and that majority is narrower. They only have 2 votes to spare on any bill. So that makes it much harder for the diverse group of Republicans to agree on any idea that can be voted on yes by all of them. There is a group of Republicans called the Freedom Caucus that has often used a small majority as leverage to, promote more of their priorities and kind of convince their colleagues to agree with them. And they released a letter this week outlining what their priorities were. I won't go through all of them, but we've talked a lot in the last year about fraud, waste, and abuse, and recent events in Minnesota have really provided an opportunity to kind of light a fire under the idea that public programs have fraud, waste, and abuse that is systemic as opposed to isolated, and that fraud, waste, and abuse is a really good reason to cut those programs. There are some members who want to do a second reconciliation bill this year. This has been an idea that's been bouncing around since really August. And it's still unclear as if they really want to do it. Remember, reconciliation is a special process. It can only be used on budgetary kind of items, and it means that a simple majority in the Senate is sufficient to pass the bill. And there have been lots of pieces of legislation recently that have used this process because it means you need fewer people to agree and say yes to get it done. That is how HR 1 was passed. With the narrower majority in the House, some watchers are saying that makes it a more delicate balance to determine exactly what legislation will move forward or what ideas will move forward, because you really do need every vote to be a yes, and you need every member to be present. And as we get farther along in the year, and Congress becomes less and less interested in being in Washington, D.C., because they want to campaign for reelection, that means it will be harder to get more, to guarantee that all of the majority members are in the same place at the same time to be able to deliver those yes votes. So it's really unclear at this point if healthcare will be another standalone bill. However, some of the ideas that we talked about in December are the same ones that are being talked about in the context of the reconciliation bill. Things like health savings accounts and lots of other kind of tweaks to the healthcare system that are outside of the Affordable Care Act and outside of the marketplace. The administration, there's been is doing a lot of things. We talked a little bit about Project 2025 throughout last year, and there is a kind of retrospective and an actual tracker that kind of looks at almost 400 policy ideas that were contained in that document and says, did they happen, or are they in progress, or have they not been started? And a surprising number of things that happened last year in the year 2025 were actually ideas that were in this document. So things like reducing the amount of staff and administratively moving parts of the Department of Education to other federal agencies. Obviously the staff reductions have happened, and there is still a lot of discussion about moving pieces of the Department of Education to other federal agencies. But there were more ideas in that document that have not happened yet regarding education, and specifically special education. So these are things to watch in 2026 to see if we see more movement towards, those policy ideas that were part of the Project 2025 plan. There were also a number of things that happened with Medicaid that were specifically recommendations of Project 2025, and HR 1 actually was the vehicle for a couple of them. The Medicaid Prove Your Working requirements was an idea that was in Project 2025, as well as reducing the amount of federal money for Medicaid expansion populations in other states. But there are a number of other ideas that might be able to be accomplished administratively, not without Congress, that have not happened yet. So it's worth knowing what those are as we continue in 2026 to know, what are we seeing some of these things be realized. Also occurring this year, the Government Accountability Office has an appointed head, and they have 15-year terms, and that term has ended for the current person. That person has actually been working for the agency for, I think, 47 years, so long-standing public servant, and he has said his appointment, I think, expired in December, and he has indicated he will be retiring. So the Government Accountability Office is a really important service agency to Congress. They are nonpartisan, and they work for Congress to ask questions and conduct audits and investigations and give legal opinions. And they were heavily relied on last year to provide an independent assessment of many of the actions that the Office of Management and Budget were doing, including freezing funds or impounding funds or changing how funds could be used or, firing workers, etc. So the Government Accountability Office is an important independent voice that kind of says, yes, the thing that is happening is or isn't, in our opinion, sometimes legal, or the money is being spent in a different way than Congress intended. And members use this agency to ask questions and then get an independent answer that they and their colleagues can rely on and see as credible. So because this is a new, this position is opening up, it means Congress, in this case, the president does not directly appoint the head of the GAO. Congress creates a bipartisan panel and will recommend a replacement to the president. But the president doesn't necessarily have to take that nomination, and the president can nominate somebody else that the Senate would then have to approve. There are people who are very worried that the Trump administration might nominate somebody different than Congress recommends, or somebody who is far less likely to follow the historically nonpartisan nature of the GAO. Many experts are also noting that one of the other actions that happened in 2025 was the elimination of federal agencies' Office of Inspector Generals. And they had a very similar role to the GAO in the sense that within the agency, they were kind of an independent observer on what the agency's actions were doing and kind of did referee, called balls and strikes on and conducted investigations on the federal agencies that they were housed within. Most of those people are gone. So really the GAO is standing out as one of the last independent voices that Congress has that they can rely on to really assess what is happening with the money that they have appropriated and in how federal agencies are acting. The recent scandal in Minnesota with the use of federal child care funding has resulted in the administration freezing federal child care funds to states until they provide more information. And they say that they are going to change federal rules about how providers are paid. So this overall fraud scandal that is actually has been is a series of scandals that have occurred over the last 10 years, is really creating the conditions where not only are other states kind of automatically impacted, but there will be changes that occur that affect those programs in response to this particular situation. And there's a nice kind of historical article here you can read. This is one of a series of fraud schemes that Minnesota has been dealing with for the past decade, where there have been federal investigations and prosecutions and convictions. And the general premise on many of these investigations is that the providers took the money and then did not provide the services for which they are paid. This really matters in the sense that fraud, waste, and abuse are often used as a reason to make it harder for people to get in or stay in programs, or as a reason to cut fundings in programs. And the article that we're sharing here has a pretty good breakdown of like what is actually happening. Lots of people don't like to see money being misappropriated. And especially to the gain of a provider. Kind of it's should say it this way. The people who rely on the providers for care are not the ones that are committing the fraud. However, they get double blamed because when those programs are cut or when it becomes harder to use them, it's often up to the individual to figure out how to navigate it. And also, when there's a dollar paid to the provider that doesn't end up translating into actual real service for the person, they kind of lose that way too. So, you know, there's a real need to address fraud, waste, and abuse. But as you can see from the House Freedom Caucus letter, this particular incident is really creating the conditions where there's going to be a lot of scrutiny across many federal programs and perhaps automatic scrutiny or big changes that may be impactful to the people who rely on them, either through reductions in funding or making it harder for the people who need the care to be able to get in. We've covered the homeless, the HUD's desire to change how federal homeless grants are appropriated away from housing first and more towards mandatory work and treatment and perhaps more facility-based care. There has been an ongoing court case, and there has been another temporary ruling. So the most recent ruling said you can't change the grant award conditions and cut funding for homelessness programs the way you wanted to right now. And the judge was really looking at the time frame that you are saying that this would need to occur in is going to leave 170,000 people homeless in winter. That seems like not a good idea. Now, like most rulings, this isn't the final one. So this is kind of a continuation of an ongoing story. And I think one of the things from 2025 is that we keep adding things to watch, and they often don't feel like we get to another step, but it isn't necessarily a resolution. And I think this is yet another, place where that's the case. The HUD administrator, however, has made some pretty strong comments about what he believes are the root causes of homelessness. And again, it doesn't seem like those are rooted in the fact and facts and experience from people who are working in this field. So, the desire to move away from providing housing to time limiting that housing and making people who are recipients of the assistance go to mental health or substance abuse or and prove that they're working. The advocates say that those three things aren't the reason why people are homeless, and they are not necessarily true of a lot of the people who are homeless. That they may not, that may not be their primary problem. So it's important again to name, what is the truth and what is the real experience, because there's certainly a lot of effort to convince people of something very different with the intent to change how public policy and how money is spent to conform with that other narrative. There are consequences when people who are not homeless now become homeless. And I think this article did a pretty good job of saying, like, look, if you don't want to pay for housing, you're going to be paying probably more in these other systems where people end up when they don't have a stable place to live. There have been some retrospectives on the changes that occurred last year in Social Security. You might remember there have been about 7,000 Social Security employees who were fired or were quit, and we've covered a number of policy changes that were put into place pretty quickly and where staff was moved around to try and fill in the gaps and implement those new policies. So first of all, again, fraud has been used as a reason to create new policies that have in turn created some barriers for people who are the primary populations of people who are using Social Security. That's older adults and people with disabilities and some legal immigrants. Um, and the data that we have available shows that there has been a pretty big increase in the number of cases that are kind of in process and how long those cases take to resolve. Social Security, if you've been trying to get through to Social Security and have thought that you were waiting longer, or that you've had to make multiple calls because you're trying to resolve issues and other things, you're not alone. Your experience is validated. There were a 6-year high in the number of calls, and that if you were trying to use the disability benefit system and found it to be less easy to use, or it took longer for somebody to respond, again, you are correct. About 90% of disability appointments in the beginning part of 2025 were scheduled within 28 days. And by December, we've seen it drop to, by about a third, that was true in only 66% of the cases. This is a nerd publication, but it does have a nice breakdown of all of the different statistical bureaus and what has happened in each and what it might mean for data collection. And the big takeaway is that, again, in 2025, a lot of the staff and federal workers who have been responsible for collecting, all sorts of data have been fired. In some places, up to 95% of the people who work there are gone. And generally, between 25 and 95% of the people are gone. And this data is really important. It matters a lot to public policy that impacts people with disabilities in weird ways. So things like the census are extraordinarily important. People who calculate what the federal poverty level is, how many different, statutes and different programs rely and look back to and point to people who are a certain percentage of the federal poverty level, where the folks that calculate that aren't there anymore. Lots of data to measure compliance with federal laws or outcomes. A lot of education data people have been gone. So, and lots of data that is used for all sorts of purposes to kind of get some measure or pulse about, what is the workforce? How is our economy? What are we experiencing more pollution or more amounts of disease? It's these data systems that have helped the federal government kind of know what they're doing and also plan for the future and also create policy that can be rooted in, what they are able to know. Things like the census, not super exciting, but like census data is used to calculate funding formulas that go to states and determine how many seats in Congress the state has. Like there are lots of ways these data sets actually play out, or they're the underpinning of what happens in public policy work and in states and in real life. Another ongoing case, we've talked about this one before too, and there's been another ruling. Beginning this week, the Immigration, Customs, and Enforcement can use Medicaid data in deportation cases. The judge limited the data. There were 22 states that sued, and I believe Wisconsin was among them. And so in those states, the data that can be shared is limited to basic biographical location and contact information. And while the lawsuit is ongoing, we don't have an end date for when the lawsuit ends, right? CMS can't give out medical information about enrollees to the Department of Homeland Security or ICE or Medicaid data in those 22 states. So if you're not one of the plaintiff states, I don't think this ruling applies. Check with your if you state attorney general. So you might be saying to yourself, but wait a minute, illegal immigrants who are illegally here aren't in Medicaid. That is absolutely true. They are not allowed to enroll in Medicaid. There are some immigrants who are in Medicaid who are lawfully present. It's a pretty, that's a small number. So why does this matter? Why is there such a fight over, sharing Medicaid data for, people living here illegally if they're not in Medicaid? Well, they aren't in Medicaid programs. However, federal law requires states to offer emergency Medicaid. So people who, are uninsured, Medicaid becomes the funding source that pays for emergency care. And for many undocumented people, the emergency room has become the place where they get care. And for many of those people, if they are not able to pay the bill independently and do not have some sort of employer-sponsored, some sort of insurance, Medicaid would end up paying for that care. So there is some connection to, does Medicaid data have some clues that could be leveraged with the Department of Homeland Security and other data sets that are now being combined across the federal government to provide more information? It is possible. It is also possible that for many families, they may have children who are U.S. citizens, but perhaps there's another family member or a parent who is not a citizen and is undocumented. So for kids who are in Medicaid, there may be some data sets that would, potentially be married with other things to provide more information about undocumented people to ICE and inform immigration enforcement. There's a theme on data that the U.S. Department of Justice is suing some states for their complete voter records, and Wisconsin is being sued. It is one of, I don't know, probably about 20 states that the U.S. DOJ is suing to get all of the voter data that the state has on file. There are some states that have already provided the federal U.S. DOJ with their data, and others that have refused to do so. Now, some voter data is limitedly accessible by certain groups, but the federal government has never collected state voter data for its own purposes. And what's in this data set? Here's the list. It has a lot of information about individual people, and again, that could be cross-referenced across different databases. I think one theme is that, sometimes people have a change in status that is not reflected in one area of data versus another database. Somebody who is an undocumented immigrant may become a citizen, may become naturalized or have a change in status. And maybe that isn't reflected in one database, but maybe it is in another. So the idea of there being more data does not mean there's fewer opportunities for mistakes. It can mean greater opportunity for mistakes. And there's real concern that this kind of data could be used to not only target individual voters potentially, but come up with ways and policies to make sure there's certain people who are less able to vote, or redraw the districts so that in order to steer election outcomes. And so there are lawsuits again all over the place about whether or not states are truly compelled to provide their state level data to the federal government. Also this week, the number of vaccines, the childhood vaccine schedule has now been changed. And there are a number of vaccines that are no longer part of the core recommendations. This decision was made outside of the committees that generally recommend changes to vaccines. It appears to be a leadership decision, but it does follow the ideas outlined in a previous presidential memo that was issued last month. So there are now fewer vaccines recommended, and kind of universally, medical associations and public health associations do not agree with not only the recommendations changing, but the reasons for them. There have been a number of folks who have said, well, other countries don't have the same vaccine recommendations, and we're making these changes to align with these other countries. But lots of experts are pointing out that these other countries are pretty different from the United States. Denmark keeps being the country that's referenced. Denmark has about the same population as Wisconsin. It's about 6 million people, far fewer than the more than 300 million people who live in the US. It also has a universal healthcare system, and the presence of disease is much different. So there are lots of folks that are saying you've changed the recommendations, but what you're comparing is not comparable, is apples to oranges. Another data story, in addition to changing what vaccines are recommended for children, states are no longer required to report the rates of vaccinations that children have who are in Medicaid or the Children Health Insurance Program. And that has long been one of the quality measures for both of those programs, that the reason for measuring vaccination rates is that is a sign that people have access to the program, and that having those vaccines is a signal that they are less likely to get a serious form of lots of diseases. And it impacts a lot of kids. There are about 40% of the country's children are in Medicaid, and more are in CHIP. So the idea of tracking how many people are immunized, it helps people understand where there are pockets of people who have greater or less vaccination rates, and also ask questions about why is that? Is that because people can't get in to get those vaccinations, or they, perhaps do not want to get those vaccinations, and or if there is a disease that it emerges, is that disease in an area where there are lots of people who might be at greater risk because the overall vaccination rate is low. CMS is telegraphing that they are moving in a different direction. Rather than asking how many people are vaccinated, they want to ask about whether or not individuals had choices and were informed of various things that might influence whether or not somebody chooses to get a vaccine. The Supreme Court is also preparing to rule on a case about mail-in ballots. It is unknown when this decision will come down. The Supreme Court usually decides to take certain cases, and it decided to take this one, and usually there is a ruling. I think there's an end date that might be in June. So we should expect that there may be some cases that the Supreme Court has decided to take where opinions may be coming out in the spring, and this is one of them that could impact quite a few voters across the country. Already, there were 4 states that changed their policies since this case has been in place, changed their laws to not allow ballots that arrive by election day to be counted. So, you can kind of see that there's quite a few people where the delivery of the mail determined whether or not their vote counted. And if it got there too late, it isn't counted. But if it got there on election day, it was. We've also seen that there have been some changes to post office policy that change when mail is postmarked. All of these things are little changes, but if you're a person who's relying on the mail to get your ballot to a certain place at a certain time, it also may mean you need to plan differently to make sure that that happens, especially if you need to get it to the clerk the day before the election instead of the day of. Very quickly, many folks we've covered how HR 1 is likely to result in pretty deep cuts to home and community-based services throughout 2025. So this is not new news in the sense that these are high-cost services that are optional under federal Medicaid law, and that they have been in the past, the first places that states have looked to reduce in tight fiscal times. Now, KFF, which is kind of the premier healthcare researcher, has come out with some materials that confirm everything that we have been saying for the last year. And specifically, they're highlighting that some of the first impacts could be shortages in home care staffing. Not only because those home care workers are part of the home and community-based service system, but one of the strategies states can use is to reduce rates. Another strategy states use is to create waiting lists or change service packages or change, policies that impact how much service people can get. These are all things that overall reduce the amount of money spent in home and community-based services that can have pretty big impacts on individual lives. And they say, very clearly the things that you have been saying and that we have been saying for some time, that tighter state budgets could lead to these cuts, not only for pay for home care workers and unpaid family care and paid family caregivers, but other reductions in the ability of home care services. It's important to note that in Wisconsin, the coverage of Wisconsin's growing Medicaid shortfall, family care, long-term care, and the Children's Long-Term Support Program were highlighted as some of the places where there was a greater than anticipated amount of spending. When you're in a place where there's a tight budget, those line items that look the most expensive are going to be where decision makers' eyes are drawn first. And in our case, many people with disabilities and older adults are in those higher cost spending lines, mainly because Medicaid is the only place where they can get those care needs met. So it is a extremely important time to be making sure that your friends and your family members and other people in the disability community are getting geared up to understand that this is something that is going to be impacting all states, and it is something where we're right. Like home and community-based services are going to be something that many states will be looking at when they have to make tough budget decisions the next time. An illustration of that is autism care. And there are already multiple states, that are cutting payments to applied behavioral therapy providers, or changing some billing policies, or overall reducing, the number of care hours that somebody can receive. For some states, they have seen a huge increase in this particular spending line. North Carolina, spending 423% more than they were a few years ago. Nebraska, 1,700%. Indiana, 2,800%. And now in the context of they know that there are big cuts coming in Medicaid from HR 1, those spending lines that have had dramatic increases and are really high cost are being looked at with a lot more scrutiny. We had one of our colleagues yesterday talking about that the proportion of what their state is spending on just ABA services is starting to be about half of what they spent on all care for their entire waiver for people with IDD. So this is an example of one expensive service. Most people don't rely on only one thing in Medicaid. So if there's one service that becomes more and more expensive in a place where the amount of money is limited, then either you have to reduce the expense in that one expensive service, or people who need all of the other things have to do with a lot less to be able to fully fund the one expensive service. There's also been a lot of scrutiny of this particular service. My colleague was quick to note that there is an increasing number of for-profit providers and private equity investing in these kinds of providers that makes him nervous that the services that are being offered might be, being looked at as a very lucrative or money-making proposition. And there have been several audits in other states, and including Wisconsin, that have really looked at improper payments. Again, some providers having billed for excessive hours, or maybe requiring that every person needs 40 hours of service when maybe that isn't necessary, or billing for care that wasn't received. And I think that's important to know as well, that when you have systems that incentivize providers to figure out a way to bring in more money, that doesn't necessarily mean that the individuals are getting the appropriate amount of care. The story had actually a provider being quoted from Nebraska who was fairly frustrated that some of his other providers were putting in policies that said, well, in order to get any care, we have to give you 40 hours a week of care. And certainly some folks were saying, well, wait a minute, the amount of therapy that's being demanded is taking kids out of school. And certainly there are also people with autism who have very strong opinions about whether ABA therapy is actually good at all. So a lot of autistic people have said, this happened to me and it was really traumatic or hard, and it might be something that the provider tells you is great, but it wasn't so great for me. So as a preview and an example, this is an example of a high cost service where it isn't sustainable to necessarily keep, increasing the cost of that one service in a time where lots of other services are also going to be feeling the pinch. The Rural Health Care Fund, again, this was authorized by H.R. 1. The first awards have been announced. You can read through and all the applications if you want to. Again, half of that $10 billion per year distribution is split between states evenly, which means that states with a smaller population end up getting kind of more per person. Okay. And the remaining half of that 10 billion is determined by CMS based on how well the state's application met their goals. We got about $200 million, and that's about the average award, but there were states who got more than that and got less. It wasn't evenly distributed. CMS is trying to say that, hey, this amount of money is really a great thing. It represents a limited time, a 50% increase for a limited amount of time. But lots of people are pointing out that this program is for 5 years and it's limited, and it isn't going to replace the nearly $1 trillion of cuts in Medicaid that are coming in the next decade. It's also an interesting wrinkle. Under HR 1, the federal agency has really a lot of ability to decide how to award this money. And lots of watchers were worried that the first awards were going to be only to some states and leave other states out. Now, that hasn't happened. There were some states that got more or less than others. But an interesting comment from the administrator is, "Hey, this is our first award, and we're going to be redoing this process every year. And we could ask states for the money back if they don't, do the policies that they said they were going to do in their application." So that is a really different approach to how to manage and award federal money, is to award the money, but put states on the hook for doing certain things, and then claw back money that was awarded if it isn't to the satisfaction of the federal agency, and also reevaluate whether or not states continue to get similar awards every year. That kind of means that what we saw this year may or may not be how these awards go the next 4 years. And how this money was awarded was also rooted in a formula, and that looked at whether or not states were doing some particular policies. And I've highlighted one of them here. Like, states got extra points on their application if they restricted SNAP users from buying certain kinds of food. They got additional points for this money if they had less rules about insurance plans, and kind of were allowing more insurance plans that lots of experts say are junk, that don't provide consumers with much coverage, that are high cost if they need to use the plans, and that don't have to conform to the Affordable Care Act. So again, it's an example of, the policy, how they designed the application, and what gave you more ability to get this money also is kind of steering policies in a way that might be more restrictive for people who are in a public program, or might lead to people having healthcare coverage that doesn't cover as much or is more expensive. With that, I am going to stop. I'm sorry it was so long today, but we had like 3 weeks of stuff to get to.
No worries. No questions. You're so thorough. Everybody, no questions. And we had a good number of people. I think we're over 140 at one point. So